the Medical AI Podcast.
Hello, I'm Dr. Felix Beacher, and this is the Medical AI Podcast, a 30-minute thrill ride of big ideas. We talk to a range of top guests, from industry innovators to scientists to philosophers. This is brought to you by Omdia and Informatech, where I'm the head of healthcare technology. Medical error has been estimated to be the third biggest cause of death in the US. Why exactly is highly complex, but one key factor is poor flows of information. And this is a problem that health informatics has long aimed to solve. My guest today is one of the few people who has a view of the field that dates back almost to its founding. He is Professor Mark Braunstein, who is Emeritus Professor at Georgia Tech, visiting scientist at CSIRO's Australian eHealth Research Centre, and author of Health Informatics on FHIR. Mark, it is a huge pleasure to have you on the podcast. A very warm welcome.
Delighted to be here.
Let me ask by way of my first question, could you just explain a little bit about yourself and what it is that you do?
Well, going back to the beginning, I grew up in a small town in the southern U.S. Somehow I became interested in computing. I really don't know how, because there were no computers in that town. The local bank had an accounting machine that you programmed by plugging in cables. I suddenly remember that, but that was all I'd seen. I went off to MIT, to a city I'd never been to and a university I'd never been to, and got really interested in computing there. The computers were way more accessible to students there than they probably were in most places in those days. And I didn't have any idea what to do with it. And a cousin who was a noted academic physician suggested I go to medical school and combine the two, which I did. And from the time I was a medical student, I started working in the field and actually oversaw the development of one of the early ambulatory electronic medical record systems in an early family medicine training program. And there I got exposed to the things that interest me to this day, chronic disease, the whole idea that computers should support physicians in making good decisions, the idea that patients should be brought into their own care, and the idea that you should not just look at individual patients, but look at entire patient populations. So for the ensuing 50 years, I have been interested in how one can successfully apply computing to patient care, a field that's been slow-moving, and it's been difficult at times to prove that the tools produce the results that we'd like. My career is really split into three parts. I was a medical academic at the beginning. I ended up starting a company based on work I had done at the medical school, and that led to a couple of other startups. And then for the last number of years, since 2007, I've been on the faculty of the Georgia Institute of Technology. Starting nearly 10 years ago, I became aware of something called FHIR, Fast Healthcare Interoperability Resources, which we're going to be talking about a great deal. And that's really been my focus for the past decade.
Okay, now you are principally known as an expert, one of the world's leading lights in health informatics. So could you just explain what that term means?
I define health informatics very simply as it's applying applications of computing, various applications of computing and digital tools to the care of patients. And there are many other sub areas, but here we're really focused on the care of patients, preventing disease if possible, managing disease successfully if it develops, making good decisions.
So, Mark, you've had a long career in medicine and in computing for medicine. So could you explain a little bit how health informatics has changed over that time?
The focus initially was on traditional care providers, mostly physicians, but to some degree, nurses and pharmacists and other providers of care. With the new technologies that we have today, smartphones, micro-miniaturized devices that can be put in the home and used directly by patients, we're increasingly focused on those new forms of care, such as telemedicine, where the healthcare provider interacts with the patient over the internet, typically, with the patient still at home and the provider in their office or at their home. And a big booming new area, remote patient monitoring, where patients use devices which could be embedded in their body or connected to their wrist or a patch on their skin, or some device they utilize that's independent, now not directly connected to them. And all of these devices provide data on a more continual basis and allow the healthcare system to understand how their patients are doing on a continuous basis. There's an old term called continuity of care that suggests that healthcare can't successfully be delivered when the patient visits the provider every 3 months or whatever it is. There needs to be a more continuous approach to that. We now have the technologies to collect the data on a continuous basis, and people are developing the informatics tools to aggregate, summarize, and utilize that data conveniently for practitioners. Another interesting new area is patient-reported outcomes. There's now a huge recognition that it shouldn't be entirely up to the provider to decide what the criteria of success are. Patients should contribute to that dialogue through outcomes that they report. And people are providing patients with apps for their phones typically to do that sort of thing. And finally, these mountains of data and the advent of sophisticated new techniques for manipulating data and analyzing data, which we'll talk about a bit as we go ahead, is leading to a greatly increased role in analytics, machine learning, to advance the field. And we're going to move on to talk about that as we proceed.
So, Mark, could you explain a little about what the problems we are trying to solve with digital tools for healthcare delivery?
Certainly. I'm going to focus on three. The first is helping providers give the best possible care. You've already mentioned that medical errors are a leading cause of death. We certainly want to avoid those. But we also want to be sure that we're providing appropriate care. There are often guidelines that are based on research and evidence to suggest what should be done to manage a patient with a particular problem in a particular point in the management of that problem. And yet studies have consistently shown that we only deliver about half of the recommended care. The big challenge here is the chronic disease problem. And in particular, the fact that patients with chronic disease often have many chronic diseases. And this is actually the largest challenge facing healthcare in most of the advanced nations in the world. There's enormous focus on high technology medicine, MRI scanners and surgical robots and that sort of thing. But the vast majority of care is the management of these chronic diseases, by which we mean hypertension, heart disease, lung disease, kidney disease. I'm sure most of our listeners have either had one of these or know someone who's had one of them. In the United States, the prevalence of chronic disease is quite high. And the CDC, the U.S. National Public Health Agency, says that 60% of Americans have at least one. but 40% have more than one. And that 40% in particular are the substantial drivers of healthcare costs in our country. And as I said, the situation is similar in the UK and in other advanced industrialized country around the world. And this is due to lifestyle issues, poor diet, lack of exercise, and of course to our aging population. So that's the first major goal, provide appropriate care. The second goal should be to make clinical decision support practical. As we're going to discuss here, the idea that computers can support physicians and other healthcare providers in making correct decisions is quite old. But making it practical has been an ongoing challenge for my entire career. The CDC the Office of the National Coordinator of Health IT in the U.S. says that clinical decision support is providing knowledge and person-specific information. I want to emphasize that, person-specific information. This isn't broad guidelines. This is your specific clinical situation. This is what should we do. Intelligently filtered at appropriate times. And the goal there is not to overwhelm providers with advice and recommendations. If you do that, then they just don't pay any attention. It's called alert fatigue. So this has to be done well. It has to be done appropriately. It has to be done at the right time in the right way. This is an illustration that this is an old field, something that you alluded to earlier. And I'm going to discuss 3 early examples of clinical decision support. I think it's going to surprise people how long ago this was being done. It also helps to illustrate the evolution of artificial intelligence, something we'll talk about a bit later. The first system what we're going to talk about is called HELP, the Health Evaluation Through Logical Processing System. Terrible name, I suppose, which used deductive rules that were actually developed through interviews with domain experts at the Latter-day Saints Hospital in Utah, which is now part of Intermountain Healthcare, by Dr. Homer Warner. I spent some time with Dr. Warner years ago watching what he did and how he did it. He started the system live in 1967, and unlike the other systems we're going to talk about, this one was used, I think, successfully for decades, and we'll discuss why a bit later. And the system consisted of a huge number of logical rules. Things like if A and B and any 2 of these 4 other findings are there, then the patient has this diagnosis. So these are rules. And it also used Bayesian statistics that relate findings to diagnosis. So what's the probability of the finding if a patient has, let's say, diabetes? That would be a true positive finding. And the false positive finding, what's the probability that a patient with that finding does not have diabetes? So the system consisted of these hundreds of logical rules and these Bayesian statistics, and based on that, it gave advice. And was used successfully clinically for a long period of time, unlike the next 2 systems. The second one is MYCIN, M-Y-C-I-N, a name that derives from the last 5 letters in the name of a number of antibiotics, such as tetramycin or erythromycin. This was developed in the early 1970s by Dr. Ted Shortliff at Stanford as his PhD. And it was an interview format. The physician would sit in front of a computer console and would be interviewed, typically for 30 minutes, by an expert system that had some 500 or 600 rules to guide antibiotic selection. And it was looking at things like the clinical context. The patient had cultures of organisms and what grew out, and clinical parameters, things that characterize the patient. He would ask questions to determine how certain it could be. And it ended up working as well as domain experts. A panel of 8 independent specialists, infectious disease doctors, trained to make these decisions were rated at about 65% accuracy by 5 faculty members. And the Mycin software got a rating of 42.5 to 62.5. So it was at the high end comparable, which is pretty amazing given we're talking about the 1970s. Then the third system is called Internist. And this was developed by Dr. Jack Myers, a physician, and Dr. Harry Popple, a computer scientist, in the early 70s at the University of Pittsburgh. And this was the first project that, from today's perspective, can be viewed as having elements of artificial intelligence. In fact, in the textbook on artificial intelligence, this is pointed to as the first application of abduction, reasoning from effects to possible causes, from symptoms to diagnoses, if you will, in artificial intelligence, which is the way doctors practice medicine. That's what doctors do. They find symptoms, they find findings, they do studies to collect data, and from those they infer diagnosis, and from that they make treatments. This system had a extensive knowledge base of about some 500 disease entities organized by organ systems, the heart, the lung, the kidneys, and so forth. Some 3,000 manifestations of those diseases, all weighted 1 to 5 by likelihood and 0 to 5 by how strongly they're associated with a disease. It also had causal, temporal, and other relationships among the entities. So this was a very sophisticated model, way ahead of its time. And incredibly important, supporting care by multiple providers. In the U.S. in particular, we have a real shortage of primary care physicians, family doctors, general internists, obstetricians, and gynecologists who have a broad overview of patients, who know everything that's going on with their patients. They don't necessarily deliver all the care, but they're aware of everything that's going on. They serve as a gatekeeper. They make sure the patients get referred to the right providers when they need it, and try to avoid unnecessary referrals, and try to make sure that the right hand knows what the left hand is doing. To illustrate how big a problem it is that we don't have enough of these providers, these patients with multiple chronic diseases that we talked about earlier get care from many different providers. In fact, there's a group of patients that's been studied with 4 to 5 or more chronic diseases. I know many listeners may have trouble believing anybody would have that many, but in fact, some people have 10. In the average year, I want to say this carefully so everybody hears me. In the average year, here in the United States, each of those patients is seen by 14 different providers.
Hang on, let's just rerun that a second. You're saying in the average year?
Yeah, the patients with 4 to 5 or more chronic diseases are seen by 14 different providers.
Which is a staggering statistic.
Right.
And seems highly dysfunctional. Okay.
Do those providers have a complete record when they see the patient? Well, often they don't. And in fact, studies have shown 20% of the time, that maybe this has changed now that electronic medical records are used ubiquitously here. I should look into that, but I didn't. But at least not that long ago, 20% of the time, they would see the patient with no record of their previous care. Now, the solution to this is sharing, effective sharing of medical records. And the technical term for that is interoperability. And that's the primary purpose of FAST Healthcare Interoperability Resources, or FHIR, the new technology that's dominated me my career for the last 10 years.
Now, I introduced you as the author of Health Informatics on FHIR, which is a clever title because FHIR means FHIR, which stands for Fast Healthcare Interoperability Resources, which I wouldn't try and say if I were drunk. So could you just explain what FHIR is?
I'm happy to. Now, it is, in fact, the first successful interoperability standard Now, it was invented by an Australian, Graham Grieve, a good friend of mine. He lives in Melbourne, approximately 10 years ago. And he was already deeply involved with Health Level 7, the global health interoperability standard setting organization. And he gave it to HL7 with some conditions that were quite clever, but I won't get into that. And has subsequently overseen the global development of the standard under the HL7 umbrella. Importantly, governments are increasingly recognizing the importance of FHIR. It's the official policy of the U.S. government. We'll get into that in more detail a bit later. And it's built into digital health roadmaps for the European Union, for India, for New Zealand, and increasingly for other countries. I think the UK is moving in that direction, and so I think slowly is Australia. Now, I don't want to get into technical detail because it doesn't really matter, but it does two things, and that's about all that listeners need to understand. It packages healthcare data in a consistent, standard way. So you know that, and the packages are called resources. So, for example, there's a patient resource. And if you ask for it, you're going to have a predictable set of data, what you'd expect, the patient's name, demographic information, and that sort of thing. There is a condition resource. So there's one condition resource for each medical problem the patient has. And it's going to have a reasonably predictable set of information. Importantly, it should tie that condition to recognize codes for the condition, because codes are really important for computer systems. And then the third one is the observation resource, where the things that the doctor observes about the patient or finds about the patient through tests and the other things. The things we talked about as important earlier when we talked about some of the early clinical decision support systems. There's something called the observation resource for that. They're actually, in theory, going to be as many as 150 of these resources, but I just mentioned 3 so you get a feel for it. The second thing it does is define how we're going to create, edit, and access these resources. And that's done through something called a RESTful API. I'm not going to explain what it is, other than to say whether or not you're even aware of it. You use RESTful APIs all of the time. When you bring up your browser and you search for fast healthcare interoperability resources or whatever you search for, you may have noticed up in the top of the browser there's a wide field that fills in with what may look like gobbledygook to you. That is the RESTful API for whatever it is that you're asking for. And it's a set of instructions which, when they reach the servers at Google or Amazon or whatever, tell them what you want, and then they know how to respond to it and give you the information you asked for. So it's absolutely critical to the internet. I should mention that the resources are also packaged using technologies that are common on the internet. So one of Graham's insights, this may sound childishly obvious, but it wasn't, believe me, 10 years ago, was that healthcare should use the same technologies that are used on the internet. Prior to that, healthcare tended to develop its own. There is another related technology called SMART, an acronym, of course, developed at Boston Children's Hospital, with the goal of creating a way that applications, the same meaning as apps on your phone, could be connected to electronic health records, and indeed could be agnostic to which record they were connected to, so that developers could write an app and it would work with any electronic health record. It isn't quite that simple, but we've come a long way toward getting there. This is also required in the United States, and other countries are starting to require it too. So we've got the FHIR standard, how to package health data, how to share it, how to access it, how to edit, how to delete it, and a set of technologies that allow apps to be connected to electronic health records because they confirm the identity of the person. Typically, it might be the physician if it's an electronic health record, but confirm their identity, and that they and or the app they're using actually have permission, have authorization to access the information it's asking for. So what does this create? Well, it creates a situation that everybody listening to me is very familiar with. You get out your smartphone and you've just read about some interesting app that you'd like to try. You can download it from the iTunes Store or the Google Play Store and give it some permissions. Remember, you've noticed your apps often ask you, can I have permission to access your location or your contacts or whatever? And then the app does its thing using the data that's in your phone. You just take that for granted. Well, that's what the combination of FHIR and SMART does for EHRs. Apps written for healthcare can be connected to the EHR, and they can access data and do interesting things. So today, as a result of FHIR and SMART, we have not just systems that work, but they've become successfully commercialized. I'll just briefly talk about Remedy. Full disclosure, I'm on the board of this company. I advise the CEO, so I'm somewhat prejudiced, but they have a comprehensive FHIR-based platform that's fully integrated into 5 major EHRs that provides management of the major chronic diseases, including guidelines of care. We talked about guidelines of care and helping physicians do what's appropriate. Clinical decision support based on the data from the electronic health record, which it can get, and on data from remote patient monitoring devices in the patient's home. And it can do this and in the traditional care model where a patient is being treated by a physician, or at a population level where a case manager in a practice wants to look at all of the diabetic patients, for example, and make sure they're within guidelines and they aren't an outlier that requires some attention to avoid complications. And this system is pretty widely installed in 40 or 50 health systems around the United States. So we're now seeing it happen. Would it have been able to happen before FHIR? I don't think so.
Now, Mark, let's talk about medical AI. Now, I think anyone who's got their hands dirty with trying to develop machine learning systems will be probably aware of the problem of curating data sets, which is incredibly time consuming and a bit tedious. Even from the same pharmaceutical companies, if you're looking at clinical trial data, for example, there can be a lot of differences between data sets that require a lot of attention. And I can imagine that this is exactly the kind of problem that a standard like FHIR would help address. And I guess this is the link between something like FHIR and developing medical AI systems.
Yeah, well, FHIR itself doesn't do AI, isn't designed to do AI, but it does do things which I think, in view of what we've already discussed, people should be able to understand, make AI practical. And we've already discussed all of them, but I'll just review. FHIR, to some degree, standardizes the data sets. Now, it isn't totally prescriptive. In fact, HL7 spent decades trying to develop and deploy really prescriptive approaches to documenting healthcare, and they weren't accepted. First of all, they were incredibly complicated because they tried to be so prescriptive. FHIR is quite fungible, can be bent by developers to meet the needs of a particular use case, but it does provide, maybe 80% predictability. And as we already said, it gives the tools access to the data in the EHR, and it allows the tools to be built into the provider's workflow and process. Second, I want to talk about is a relatively new, well, it's 5 years old, Silicon Valley-based company called Curai. That's spelled C-U-R-A-I. And their goal is to reduce the cost of telemedicine. If you get a remote patient visit here in the United States, the charges from a physician, the charge is likely to be $75 to $100. They're using FHIR and a FHIR-based EMR that they developed to allow a bot to interact with the patient. There is human physician, nurse practitioner, and so forth review, but an automated telemedicine visit. They've also got their bot taking patient histories. Everyone who's listening to this has probably had the pleasure, in quotes, of being handed a clipboard when they visit their physician and asked to record their recent patient history. Drives me crazy. They're doing some of that, although the company cautions that it's going to be quite some time before regulatory approval allows what they call unrestrained chatbot interaction with patients. Their system creates a patient log, and from that they use GPT-3. Aha, you knew I'd get around to GPT at some point, didn't you? Now, everybody's talking about Chat GPT, and that is the chatbot, the program that you interact with, that you can talk to and it talks back to you. But the real brains, if you will, sitting behind that is just called GPT, and we're currently on the third version, GPT-3. And the company's using, and you can use that. You don't have to use the chat box. And they're using it to do something that sounds mundane, but is actually incredibly important. It synthesizes the patient log. So it looks at all the prior interactions with the patient and gives the next physician a summary of what's taken place. Now, why is that so important? Well, we talked about that earlier when we said that patients are seen by multiple doctors, and they may not have a complete record. What I didn't say then, but I'll say now, is even if they have a complete record, if the patient has multiple problems and is being seen by multiple providers, that record is going to be huge, and they just don't have time to go through it all and properly summarize it. So the notion that not a chatbot, but I guess it's the bot, can do that summarization for them is very interesting.
So I'm sure people are asking themselves, if a typical, I don't know, let's say somebody has a kind of mysterious infection and they want a teleconsultation with a doctor, and it costs, I don't know, let's say $100. People will be asking, well, how close are we to being in the situation where I can do that with an AI system with the same level of interactional functionality and the same level of accuracy, but maybe for half the price? How close are we to that kind of thing?
Well, this company's already doing it. Now, I can't say that it has the same level of quality or accuracy. We'd have to talk to them, and obviously they believe it does. But the company's 5.5 years old. It employs 60 people. They've done hundreds of thousands of these visits, mainly paid for directly by patients at a fraction of the live telemedicine cost. I think $15 is the price, but I may remember that wrong. So it is certainly starting to happen. And it would seem that as these chatbots get better and better, it's going to happen more and more.
It's a fascinating prospect. If an effective AI system becomes widely available, then it could change things radically very, very quickly, I would have thought.
Well, the company tells me that they're starting to work with retail pharmacies, insurance companies, and provider groups of physicians. And they're interested in talking to the large-scale integrated delivery networks that we have in the United States.
Yeah.
So they're reaching out to the broader market. Going back to your question, if the interaction, and I'm sure this is true, but I didn't ask. I'm sure the interaction is limited to specific problems where they have solid evidence-based protocols that the bot is using. And that I doubt they shouldn't turn a bot loose to try to diagnose some complicated medical problem.
No, but in principle, it could be extended. I mean, the principle is there, right?
Yes. Now, a startup just started last May here in New York is Abstractive Health. And it's based on its founder's research at Cornell Tech, the relatively new school here on Roosevelt Island in the middle of the East River. And they're using FHIR their goal is to summarize patient records. And they're going to start with Epic, which is the most widely deployed electronic health record among major health systems here in the United States. The summarization module is complete, and they're now working on using FHIR and an older HL7 standard for interacting with electronic records or electronic healthcare systems to get admission, discharge, transfer, and scheduling information, not clinical information. And the reason they're doing that is they're envisioning that their system would continuously monitor to see if the patient is scheduled for a visit or has been admitted to the hospital and would automatically update its summary based on the information from that visit or that hospitalization. So when the physician next sees the patient, they've got a completely up-to-date summary. A very interesting, I think, clever trick. And this coming April or May, they hope to start work in the emergency department of New York Presbyterian Hospital, which is actually where I get my care. So it's a very good choice because emergency department physicians almost always see patients that aren't known to them. So a summarization would be very helpful. Having worked in an emergency department as a student, I can assure you it would be helpful. And of course, in an emergency department, time is of the essence. So the physicians have less time than even ordinary physicians to try to summarize all the past information themselves. They considered a number of open source language models for their use and ended up choosing Facebook's BART model. Everyone is talking about GPT-3, but there are other models for doing what GPT-3 does. Google has one called BERT. Facebook has one called BART. And OpenAI, the company that produced GPT-3, has one called GPT-2, which is open source. So you can take any of these models and you can host them yourself. Mm-hmm. And that's important in healthcare because generally you can't put protected health information on someone's cloud unless that someone is willing to sign a legal agreement defined by the federal government. And OpenAI, the company that's produced GPT-3, the chatbot GPT engine, hasn't open sourced it, and they won't sign one of these agreements. So the company ended up deciding that Facebook's BART was the best choice. I just go into that because people are going to wonder, well, why aren't they using GPT-3?
Yeah, right.
And BART was actually specifically designed by Facebook to do summarization, like the news. So when you see news summaries on your Facebook page, they've gotten it from sources, and BART has done the summarization. A human being hasn't.
It's fascinating.
And the company has one other interesting comment. Despite the fact that FHIR delivers structured information, coded information, I mentioned that earlier, they find the unstructured, free text data of particular importance to doing the summarizations because in those notes, the physician says what's important to them. So there's a big difference in their view between the clinical laboratory noting that a test result is abnormal and a physician noting that it's abnormal because clinical labs produce abnormal test results all the time that really aren't of any great clinical significance or may in fact be normal for this patient. This patient just always has an abnormal whatever it is. But if a physician takes the time to note it, then it probably has clinical significance. So I thought this was a very interesting example of how natural language and unstructured text is going to be continuously of importance, even as we move forward.
Fascinating. And I don't think that was particularly talked about even a year ago very much. Not as much as, the classical uses for machine learning.
Well, this is really state-of-the-art stuff. I mean, this is a company that's not even a year old.
Right.
And their planned outputs are a note that when you're done, when the emergency department physician is done with the patient, they write a note for the physicians in the hospital who are going to take over that patient's care once they're admitted. And the bot's going to write that note. Now, Abstractive Health has a forthcoming paper, which it hasn't yet been published, but I'm quite certain it probably will be, given what it says and who the authors are, where they compared the narrative part of a discharge summary produced by their bot to the same thing produced by a physician. So a discharge summary is a long summary of what went on when a patient was in the hospital. A long write-up, not a summary, a long write-up. And their bot summarized it into a paragraph, really, and then a physician did the same thing. And they did an evaluation where 2 board-certified physicians evaluated the output of the bot versus the output of physician. Mm-hmm. And their ratings were pretty similar. To be fair, they did rate the physician a bit higher, but not that much higher. And when I looked at it, I must say that they both made errors of omission. So what does all this mean? Well, we do seem to be heading in a direction that chatbots and bots in general, machines that manipulate natural language, are going to be able to conduct at least some forms of patient care.
Yeah.
And are going to be useful tools to save physicians time and avoid physicians missing important things that are buried there in the chart, but which they just may not find because of the amount of time they have.
So, Mark, I just want to thank you very much indeed. And it would be great sometime if we could have you back and we can explore this a bit more.
Well, I thank you for having me, and I've certainly enjoyed it, and hope that the things I said are of interest and of some value to the listeners, and I would be delighted to do another one sometime.
Thanks so much, Mark. Bye-bye. Thank you for listening. I'm Felix Beacher. Ping me on LinkedIn for more information on Omdia's services in healthcare technology. See you next time.